Welcome to Shielded, the podcast dedicated to helping Florida's first responders understand the laws that affect their work and their lives. We bring clear answers, practical tips, and stories to help you when you need it most. If you're a first responder in Florida, this is your playbook. Be sure to check out all of our resources at bicklerlaw.com. I'm your host, Paolo Longo, and I'm here with my partner, Jeff Bickler. At Bickler & Longo, this is what we do. Now let's get into it. All right, welcome back to the show, everybody. Today, we are joined by a special guest, Dr. Alex Chernobelsky. He is a board-certified cardiologist. He practices down in Palm Beach, Florida. He's treating patients, first responders from a wide range of heart conditions, including coronary artery disease, arrhythmias, and other serious cardiovascular issues. He's had a lot of experience treating first responders. He's been an authorized treating doctor for these heart bill claims for many, many years. He regularly works with first responders, law enforcement, firefighters, corrections officers, and he provides a real world clinical perspective to these cases. And today we're very fortunate to hear his thoughts on these kind of claims on heart disease, preventative medicine. It's going to be a great episode. So thank you for your time, Dr. Chernobelsky. Welcome. How are you?
Thanks for having me. Great. I appreciate the opportunity.
Well, we appreciate your time, and I think, our clients who have you as a doctor and those of, the rest of in the first responder community are very lucky to have you treating them. And so we hear a lot of good things about you. And so I'm grateful that you've given us a little bit of your time to talk about these cases. So from your perspective, Dr. Chernobelsky, what do you think, if anything, makes first responder treatment of heart disease different than, your regular population of your patients?
Sure. Very specific population with very different culture, very different idea of disease, and very different presentation oftentimes. We have to remember that most first responders are very fit individuals. They do not look like your typical person with coronary artery disease or arrhythmia or anything else.
Right.
There's also a specific culture of inner strength and denial to a certain extent. So people do not present with mild complaints. Usually by the time people see me, the wheels are kind of coming off, so to speak. It's the last ditch effort. At the same time, the incidence of disease is significantly higher, in my experience, than general population. The asymptomatic or minimally symptomatic disease that I see, severe disease that I see in first responders, I should see these cases once every 2-3 years. And I end up seeing them every week, every 2 weeks, maybe. So at this point, I had to rethink the incidence and the risk stratifications that I'm used to in regular population and apply different standards to first responders.
Yeah, when you talk about risk factors, first responder risk factors versus that of the general population, right, of just, average working folks or regular patients, I mean, how do you see those different?
Well, the sleep deprivation, the constant stress, the adrenaline surges, all of that must end up changing the incidence of the disease. But again, just from personal experience, taking care of this population for the past 20 years, I am not supposed to see this prevalence of the disease. I'm not supposed to see, by our standards, the severity of disease in people who look, like fitness model oftentimes, like, they've been working out all their lives. They look healthy. They will tell you that they feel healthy, and they end up with, stents, surgeries, ablations, real disease with real treatments.
I think, those are two really, really interesting points that you raise. Number one, about the fact that you see these cases many times when the disease is already very advanced, right? Because maybe there's been a reluctance to get treatment or to control other risk factors like, cholesterol, or to get on a treadmill, or, whatever it might be. And then also, like you're talking about, the prevalence of the disease. So, from our perspective, and I think from a public policy perspective, those are really two critical issues, because we could definitely benefit from earlier intervention in these cases. I think you would agree with that. And it's certainly what you're seeing, I think, is it fundamentally reinforces the idea that this presumption is important in this population. Because, we hear a lot of times, why do we have this benefit for these first responders? And why do these guys get this heart disease protection? And, and on about that. But what you're pointing to is exactly the reason we have it, right? Because of the things like sleep deprivation and adrenaline rush and adrenal response and all the things that, that we see, that actually is a very significant factor in the development of heart disease, is it not?
It seems to be.
Yeah.
And like I said, from my experience, my experience certainly would support that. And there are just multiple cases that come to mind, multiple patients who look phenomenal, who feel well enough,
Right.
who will tell you that they're able to, perform amazing feats of strength that end up with significant disease. And then going back, I usually hear, oh, I didn't realize that I wasn't just tired. I didn't realize that I wasn't just getting old, from somebody who's in their 40s and 50s. I didn't realize that it wasn't just, sleep deprivation again. So yeah, it's very real, it's scary, and it's extremely important for provider to question these individuals in a manner that is different from general population.
Yeah. That makes a lot of sense.
Yeah, and are there or is there a diagnosis or are there different diagnoses that you see that are more prevalent within this population than as the general public? Or is it just the run of the mill same stuff, just at a higher rate?
I would say it's same stuff at a higher rate. Again, my patient selection may be skewed because of people that I'm being referred, etc., from different places, but I certainly saw more unexplained cardiac arrests in cops than in any other population that I can think of over the past 20 years. Again, healthy people without coronary artery disease, without other issues that have severe life-threatening arrhythmias. I'm sure you're familiar with some of these cases. Coronary artery disease that seem to be happening earlier, seem to be happening without many other risk factors.
Right.
Coronary artery disease that seem to be minimally symptomatic, even though severe. Certainly hypertension is extraordinarily prevalent.
Yeah, that's an interesting point too, that you said it was, younger and younger. I mean, when I first started handling these cases, there was primarily the older guys, right? Late 40s into their 50s that you would start seeing this stuff. I talked to a guy today, okay, 30 years old, had a bypass, no smoking, no obesity, no prior hypertension, no family history. He actually did the genetic testing for the familial hypercholesterolemia, came back negative, 30 years old. He'd been a firefighter already, I think 12, he started at 18, right? So
Wow.
about 12 years, 30 years old, and he ended up with a bypass. I mean, that's a record for me.
Yeah, it's unfortunately not a record for me, but very young. Yes, absolutely, and also
Troubling.
important to identify that the two populations of first responders, firefighters, and cops, oftentimes need different approach and different treatments, and oftentimes they cope with stress differently. And that's just something that, again, taking care of these two populations, it's important for provider to know.
Yeah, well, you mentioned something earlier about, I guess, as a clinician, right? When you're talking to these people, when you first,
Sure.
meet them and you're asking them and you're sort of interviewing them and you're getting the history and everything. And that, you said that it's different than with, non-first responders, right?
Sure.
Is that more, I don't imagine that would be more towards diagnosis, but more towards how to be preventative or how to treat the disease?
It's how to figure out what's wrong with trying to get person to tell you what it is that they're feeling, because a lot of times they're not aware that what they're feeling is not normal or is not okay. The difference that I was referring to in populations, for instance, firefighters, to them, threat comes from the environment and they band together to combat that threat. They live together, they talk together, they eat together, they work together. Cops, to them, threat comes from other human beings. They tend to be more, I wouldn't say loners, they're very sociable guys, but they tend to look at other people as potential threats.
More suspicious. Yeah.
Even their lawyer, by the way.
Yeah.
Well, even a
No, I
physician.
mean, that's just a really, really important point in terms of the personality differences and how they operate in the world.
And there are, for instance, there are rooms in my office. We have multiple rooms. There are rooms that are too small for me to see a first responder. There are rooms in my office that I will not see a police officer with because I would have to get too close to them. I would have to invade their personal space. There are rooms where, for instance, the patient would face away from the door, and they do not
They
handle it.
won't do that.
They
Yeah.
will not do that. So those things are just, and immediately the blood pressure goes up, the heart rate goes up, and
Right.
it's in a very predictable, in a very measurable way. So, and speaking and trying to elucidate symptoms oftentimes require a little bit different approach. Not so much, do you have chest pain? Do you have shortness of breath? Do you have this? Do you have this? But more general approach, as in what difference have you seen between now and 5 years ago in terms of what you can do or what you have done? Have there been instances where you would think something physically should be easy, but it's not, or harder than it should be? Have your significant other or other people around you commented or noticed that, you were slowing down, or, have there been any comments of them worrying about your health? Things like that. And it's very hard for people oftentimes to admit that their exercise capacity went down. I mean, we're talking with a lot of alpha personalities, a lot of proactive individuals, who want to be on top of the world, and in their minds they are, and professionally they are, and it takes enormous beating physiologically. Another point I would like to make, and I think it's an important one, it seems to affect people, coronary artery disease and other diseases seem to affect people who, quote unquote, handle stress well, end quote, more. It seems counterintuitive, but it's sort of like if you don't handle stress well, you're not going to be in the job long
Right.
enough.
Right.
If you play football and you hit your head a couple of times and you really don't like it, you're not going to be there long enough um, to get a concussion syndrome. It's only those individuals who, quote, handle it well, stay for 10, 20, 30 years,
Right.
and their
Yeah, you're
injury.
selecting, the profession is selecting for that type of an outlook or
Absolutely.
personality type, right?
Absolutely.
Yeah.
Absolutely. And those are the individuals who internalize the stress,
Right.
who end up with physiological damage.
And, many times mental issues are resulting from that as well,
Sure.
which I
Right.
know you wanna touch on that later, so that's important.
Yeah, and so you mentioned a couple of times that these are primarily really physically fit people, strong people, fitness looking models. You see the calendars with all the these buff guys and stuff. But if you're in a room, right, and you're talking to 100 or 500 first responders, and they all say, "Doc, I feel fine. I'm no problem. I do everything I'm supposed to do." What are some pieces of advice that you can give them to try to really reiterate the preventative part of this? I mean, what do you tell somebody that
Yeah, I
says,
mean, I think that's really an interesting question too, doctor, because, yeah, if you're just talking about the run-of-the-mill person going to see a cardiologist and modifiable risk factors, then they'd probably say the first and most important thing to do would be exercise, right?
Sure.
I mean, but is it your experience that with this population, that's not something you really need to stress because they're already doing it, or, what are your thoughts on that?
There are certainly some individuals that could benefit from it, but majority certainly are already very physically fit, very physically active,
Right.
and not particularly overweight. I mean, obviously there are some that are, but who otherwise look like well-fit individuals. And in that population, what I would say is make sure that you monitor for changes in your exercise capacity. For
Yeah.
instance, if you routinely run 10 miles and now at mile 7, you just can't go any further, with understanding that everybody can have a bad day. But if you're consistently just hitting the wall, or, you're lifting weights and you go, I should be able to do this, and now for some reason it's harder that I would think it should be, that may be a signal. Now, it may not be, everything may be perfectly fine, but those are the first things that show up. I mean, by the time that you have elephants sitting on your chest,
It's too late.
right, everybody knows what to do at that point. It's getting to that point. Don't assume that it's, because you work for 16 hours or because, you're sleep deprived or something else.
Right.
What do you recommend in terms of testing for that, for the exercise capacity, like a VO2 max test, or does it need to be that advanced? Or
I haven't used VO2 max. It's a good test. It's a good physiological test, but I don't think it's necessary. In terms of coronary artery disease, I think calcium score gives people an amazing insight in their long-term risk. It's easy, it's
right,
inexpensive, most of the
right,
time it's free. But I think most important is to be self-aware, to be proactive, to establish relationship with the provider that you are comfortable talking to and comfortable confiding in, and somebody that you can call and say something is not right. Some of the best diagnostic outcomes that I have seen were from patients who never complain of anything, who call and say, "Doc, something is not right." I
right.
feel just it's kind of silly me telling you this, but I just don't feel myself. And you need to have a provider who doesn't ignore that, but goes, okay, that's a signal. We need to follow up on that. And that's something is not right. That intuition, that knowledge without awareness where it comes from is absolutely golden. And I cannot tell you how many people I have seen that ended up with significant disease, just not from because they had chest pain or shortness of breath. They continue to exercise, but they just don't feel themselves. I think that's probably would be one sentence that I would want everybody to listen to and to know.
Yeah, that's good stuff. And so kind of changing gears a little bit, and we touched on this a little while ago. It used to be there's like kind of two parts to the first responder stuff, right? I mean, you had the heart disease on one side of the coin, and then you had mental health on the other side of the coin. Okay. But as time progresses and as these cases kind of develop, we see or we're seeing, I mean, Jeff and I, specifically with talking to clients, that we see that these things really aren't very separate, right? That they're the two sides of the same coin,
There's a
right?
connection for sure.
There's a huge connection, right? And practitioners and people that handle these cases and see them every day, like folks like Jeff and I in our firm, we see they're hand in glove, right? But now we're starting to hear from doctors, right? And it's funny because you and I had this conversation a couple of weeks ago, and I know you and Jeff even had this conversation a couple of years ago, where you're starting to see as a cardiologist the interplay of the mental health, the PTSD, those kinds of things, and how it's affecting even your ability to treat them physically, right?
Absolutely, 100%. And Paolo, there is a very simple, well-described, predictable physiological mechanism that is responsible for that. There is nothing mysterious about it. There is a way that PTSD affects cardiovascular system. There is a way that it can be treated, and it's reproducible from person to person to person. At this point in time, I can probably tell who can have PTSD, not because they're complaining about it, but based on their cardiovascular outcomes and their cardiovascular complaints. And the interplay is very simple. Now, I don't treat PTSD. I'm not a psychiatrist. I'm not a psychologist. Those are significantly, in my opinion, smarter people than I. My view of PTSD is very mechanistic. There are certain things that occur in central nervous system, peripheral nervous system that happen during stress and during PTSD. It's sort of like in modern gas-powered cars, when you step on a gas, certain things happen. The computer, the ECU, detects that you stepped on the gas and it increases engine speed, it shifts into the right gear, it increases fuel consumption, it increases cooling. In some cars, it may change how loud the radio is, et cetera, et cetera. And it's very predictable. Same thing happens in the body when the brain detects that there is a threat. There are specific, well-described, well-known physiological things that happen. Heart rate goes up, respiratory rate goes up. You're running away or fighting a tiger, right? It's fight or flight response.
Blood pressure goes up, right?
Absolutely. Blood pressure goes up, your vision changes, your pupils dilate to let more light in because you need to see more. You start sweating because you need to cool down the muscles that are about to work. Your liver starts producing more glucose. You decrease perfusion, you decrease blood flow to digestive organs, to reproductive organs. Now a lot of times people say, well, PTSD is like running away from a tiger type of thing. And I think people kind of miss this because what I've described so far is a normal response to stress. PTSD is not when you're running away from the tiger, it's when you're running away from the tiger and realizing that the tiger has won. So it's that level of trauma that resets, back to automotive analogy, it resets the ECU. So now your body, your brain thinks that you are pressing on the gas all the time, and your heart
Right.
rate is up more often than not. Your blood pressure is up more often than not. You're having
Right.
digestive symptoms because you are shunting blood away from it,
Mhm.
et cetera, et cetera. People have a certain look when they're in the midst of PTSD, and that comes from different blink rate, from different dilation of the pupils. You can, if you've seen enough people with PTSD, you can pick it up. It's hard to explain, but there is definitely a certain look.
But that's interesting. So, I mean, did you just start noticing this over time? Like, you're trying to treat somebody, but you can't keep their blood pressure under control. You can't keep their,
Absolutely.
the medicine's not working. And then finally you just say, hey, what else is going on? Is there a mental health issue here? Is there
Well,
PTSD? I mean,
yeah, and
how does
actually
that work?
and that was our discussion a few years ago, doctor. I mean, you had identified, I think, some studies that were talking about this very issue and PTSD and controlling blood pressure. And, that was sort of the first time I really thought about the interplay with respect to these conditions. Yeah, if you'd talk more about that, I mean, to me, that's absolutely fascinating. And also, potentially a modifiable risk factor that, we need to address. I think from a legal perspective, if we're going to help these folks, you can't just patch them up from a cardiovascular perspective and then, not deal with the underlying, this other mental health disorder that may contribute to making the condition worse, right?
Well, and I'm going to argue that PTSD is not just a mental nervous injury, but that it can also be a physical injury, right?
Mhm.
Because of what the effect that it has on your body physically, right? I mean, high blood pressure is not in my head, right? I mean, high blood pressure, that is a measurable physical thing that I have to treat medically, right? I mean, if I have, if I got pink eye, I'm going to put medicine in it, right? I mean, if I got high blood pressure, you're going to give me medicine. And because if my PTSD is causing me to have hypertension and to have to take medication to now control that, right? I'm going to argue all day long that legally, also medically, but legally as well, that's a physical injury, right?
Well,
Well,
not to interrupt you, doctor, but I mean, this is a really compelling legal point, right? Because we typically are operating under the presumption of the heart-lung bill, the presumption that the condition is work-related. But what Paolo is describing is actually an alternative theory of liability. If we had a problem, for instance, on a pre-employment physical, or we couldn't rely on the elements of the presumption and prevail using the presumption, we could make this alternative argument that the post-traumatic stress is potentially causative of the hypertension and we don't need the benefit of a presumption, right? So this is an extremely interesting and evolving area, I think, of both medicine and law.
well, certainly from medical perspective, like you mentioned, there are very quantifiable, predictive physiological events that happen in some patients with PTSD. And we treat them oftentimes by using drugs and procedures to decrease the effects of adrenaline on the heart, on the blood vessels, also on the brain. And we use things like beta blockers, alpha blockers, medicines and procedures that decrease release or action on tissue of adrenaline, and it is helpful. So it's definitely real. It's very predictable when you see it. When you've seen enough of it, you see patients with hypertension that is just impossible to control, or
Uh-huh.
patients with hypertension whose hypertension had been controlled on one, two, or three medications. And one of a sudden, there is nothing that you can give them to
Wow.
keep their blood pressure. I'm not even talking about normal, just keeping them out of the hospital becomes the priority. And then you get there's one particular person that I can think of when we started talking and said, well, is there something going on at work? And immediately the answer is no. I've been doing this for 30 years. There's nothing new. Well, when did it start? Well, it started after, I reconstructed another crime scene, and he described the crime scene. And then he goes, well, maybe I've just seen too many, dead people at this point.
Yeah.
In when I talk to patients about PTSD, and I have some veterans too who have experienced severe trauma. I think maybe the trauma is somewhat different in veterans. Usually it's sort of like a closed head injury. It's severe injury that, people live through events that are horrific. And it's that usually one event
Right.
that leads to PTSD.
Right.
I think it's important to understand that in first responders, that certainly could be the case, but it doesn't have to be. It can be a repeated injury that may not rise to the level of, combat,
Right.
but it's sort of like football players getting 1, 2, 3, 10, 20 concussions, and you don't know which, proverbial, you know, um,
Which event
straw.
caused the yeah, I mean, it's
Exactly.
not like one event caused the problem, right, doctor? I mean,
Right. So it's
that's what
accumulative.
we see so consistently in our practice. These clients, they can't speak at, about one particular event. I mean, they may have a whole catalog of things they can tell you about horrific events
Sure.
that they've seen.
Right. It's a whole career's worth of traumatic calls,
Yeah, they're
right?
not laying their condition on any one thing, and unfortunately, our current PTSD law doesn't allow us to address PTSD, through that type of chronic, repetitive, traumatic events that they might be witnessing or experiencing. So, that's something that Paolo and I and the firm, and we've been working on trying to get some revisions to the PTSD law. But it's such a valid and such an interesting point that you're making there.
Well, again,
But
Jeff, physiolog
how does that change your treatment, right? I mean, if you've got a cardiac claim, you're treating somebody for heart disease, does your how you manage that patient change a whole lot if they also have PTSD or some other kind of a mental nervous
absolutely.
injury?
It absolutely does. So there are different medications that I may use. I specifically may use medications that decrease release of adrenaline, or like alpha blockers, clonidine, that is also used for treatment of PTSD, which I normally rarely use for hypertension, but in patients with PTSD, it oftentimes helps both. And again, it's not magic why it helps both. It helps both because there is one very specific physiological mechanism by which it works. Beta blockers, to a lesser degree, first responders tend to not like taking medication that alters the effects of adrenaline, but it can be extremely productive as well. Another somewhat experimental, but not really, procedure that I have referred several patients to with phenomenal results has been a stellate ganglion block, which is an injection to decrease the signaling from the central nervous system, from the brain, to adrenal glands and the nerves to release less adrenaline.
Wow.
And
Wow. Who does that? What kind of
Yeah,
doctor? Where do you send somebody to do that?
pain management.
that's pain management. Okay.
Management. And I have to be very, very specific about this, especially for people listening. This is not to necessarily treat PTSD. There were multiple studies, especially at the VA. I recently reviewed them that showed mixed picture. Some people really benefited from it, some people did not. And interestingly enough, people with more anxiety related symptoms from PTSD benefited more. Well, to cardiologists, it's fairly simple explanation why, because it's adrenaline driven. So yeah,
Right.
those people. So I don't use it in order to treat PTSD. I use it to decrease the physiological effects of PTSD on patients with blood pressure, with patients with heart disease, patients with arrhythmia, with incredible success, actually.
Wow. I mean, is that something that you've recommended, or prescribed for workers' comp patients? And how has that been received by, adjusters who are looking at, the bottom line on a claim and, oh my gosh, this is going to cost us a lot more money. I mean, have they been receptive to that type of treatment?
Well, it certainly depends on, I guess on your counterparts. Sometimes yes, sometimes no.
Okay.
Again, this is not to treat PTSD.
Right.
I leave it to people who deal with, software,
Right.
basically, psychiatrists and psychologists. But for physiological results, absolutely.
Well, I want one of those. I want one of
Yeah,
those kits.
I think
I want to
Apollo
try
needs
that.
that.
I want to try that. I want to try that.
Maybe
Well,
instead of, that Manhattan tonight, you get your ganglion
yeah.
block.
Well, but what it does, Jeff, it resets the idle speed back to normal. So
That's
it's
amazing.
the
Yeah.
the issue, and the issue especially with repeated injury that may be worth spending a couple of seconds on, is that when you go from zero to hero, when you are on extremely stressful call or a fight or whatever the case might be, your body releases enormous amounts of adrenaline. Then you kind of detox from it. You have, your adrenaline rush and you come down. Well, the body remembers it. The brain is just a basic, huge predictive computer, and it gears up for the next time it happens.
Mhm.
And when it happens the next time, it's easier to go to that 10,000 RPMs because you're not idling at 2,000 anymore. You're idling at 3,000. And the next time it happens, it's even easier and easier and easier and easier, up to a point where your adrenaline level is so primed, if you would, that it takes very little.
Mhm.
And, there have been multiple studies that show that the increased adrenaline concentration is actively toxic to cardiac cells, that there are specific physiological things that you can see in the heart. There's, the mainstay of treatment of coronary artery disease and heart failure is the blockade of the adrenergic system with beta blockers that we've known for, 30 years, 40 years at this point. So, again, all of those things are physiologic, they're quantifiable, there's no mystery to it. It happens in a very predictable way, but it also, because of that, it offers a target for therapy. And for
Mhm.
instance, with stellate ganglion block, resets, that hopefully back to normal. Sometimes people need, there are two ganglions, one on the left, one on the right. Sometimes people need both injected. But at the same time, you still need to have your PTSD treated. This is not
Right, so that would be treated with a psychiatrist through, end therapy, right, traditionally.
absolute.
And just, curious, I mean, do you even have, like, a percentage of your clients that you think would benefit from, psychological care and counseling? I mean, is it 20, 30, 50%? I mean,
I
any idea?
Well, I think all of us would benefit from that.
Great answer.
Us two
Great answer.
first. Us two
Yeah.
first.
Yeah,
But
exactly.
to the degree that I
Well, is it to the degree it's medically necessary? I mean, I guess that would really be the point,
yeah,
right?
I think it's I think as far as ganglion block, this is an only, I have tried it in only very severe cases.
Okay,
But the psychological treatment, I mean, I would say vast majority would
okay.
benefit. I mean, it's not, as I'm sure you know, when people retire, their blood pressure goes down dramatically, certainly more than any drug that I use.
It's so funny you say that. I talked to a guy earlier this week that he had a blood pressure claim. He went to retirement with it. As soon as he retired, he didn't need the medication anymore, and he was absolutely fine. And of course, he wanted to talk about the value of his case and potentially settling it. And I said, well, bad news is you haven't really got much of a case there anymore. The good news is you're healthier now than you were when you left, right? So
It's absolutely true.
I was going to ask you, I just think this interplay that you've identified here is so fascinating that, might be worth doing a little breakout, maybe at WCI this year. We're actually coordinating something for WCI and public safety officers. And, like we did a few years ago, I don't know if you recall that we had that. Basically, it was almost a full day of programming. I would love to have you on a panel to talk about this in more detail if you'd be interested in that.
Absolutely.
Yeah, imagine we put a cardiologist on the PTSD panel.
I absolutely, this is exactly what I'm thinking, Paolo, right?
No,
So,
agree because I mean, we've known for years that this is the
Right,
problem, right? I mean,
right.
we see this in, how many hundreds of clients over the years that this is a consistent, regular issue. I mean, these things are not separate, right? And you can't look at each of them in a vacuum, right?
Right.
Because they both affect each other. And so finally, it's nice to hear, to get a doctor to actually talk about it, right?
No, it's again, it's if you see enough of these patients, when you take care of enough of these patients, it's impossible to ignore. As far as the cost and for instance, of the procedure, it becomes extremely cost efficient because it saves multiple hospitalizations.
Right.
So
Right.
just recently, I can think of one particular individual who kept going back to the hospital because of the coronary artery spasm. And we know that coronary artery spasm oftentimes it's not a common disease, certainly it's rare, but it can be caused by increased adrenaline.
Uh-huh.
And this individual got stellate ganglion injection and hopefully significantly decreased not only him feeling symptoms, but also, the medical expense that is incurred by him going to the hospital and getting all the testing and missing work and on and
Uh-huh.
on and on and on. We're not talking about surgery or cost prohibitive procedure. I don't know what it's caused, but it's hundreds, not thousands of dollars. So it tends to be when it works, it tends to be very cost efficient. And I haven't so far seen
Well,
it
and
not
yeah,
work.
and maybe that's the thing. Obviously, if you can convince the insurance adjuster or the risk management team that, they're ultimately going to save money in the long run, they'll see the value in that rather than just, knee-jerk denial of, well, what is this? And it's just an additional expense on a case. I mean, if they can see how ultimately it's going to save them money, then that's great for everybody, right?
Yeah, absolutely. And I've been lucky to work with adjusters um, who care and
Right.
who have mostly the benefit of their client, in mind. So it's been very fulfilling from that perspective. And I tend to not work with those who don't.
Well, yeah. Yeah, I'm sure there's a number of adjusters in the state obviously handling these types of claims that they blow their top if they start hearing about ganglion blocks, all right?
Right. Leave that to us. We'll take care of
Yeah,
that.
we'll take care of it. We'll litigate it if need be and try to get the care taken care of.
Yeah, yeah, and Dr. Chernobelsky, it's been really enlightening and enjoyable talking to you, and
Likewise.
sort of wrapping up, if there's one thing that you would want the first responder community, to take out of this conversation, I mean, what would it be?
I would say confide in your provider, get healthcare provider who cares, who's experienced with this population, who you can trust, who you're comfortable with, and establish relationship early so that they get to know you and they can sense or see if there are changes. And really, as far as preventive care, look for changes rather than severity of the symptoms.
Right, that's a good point because a lot of people don't they wait till they have a symptom, they're not paying attention to
Yeah.
changes, daily or monthly or yearly.
Yeah, I
So
love that advice about, exercise output and just noticing a dip or a drop in your ability to perform. I mean, I think that really is a warning sign that people can be aware of. So whether it's a VO2 max test or, even just a stress test or a calcium score testing like Dr. Chernobelsky is suggesting, those are all things that people can be proactive about. So all great advice, doctor. Thank you.
All
yeah,
right.
it's been great having you on, doc. I appreciate it. Thank you.
And I'll be in
Likewise.
touch with you about that presentation at WCI because I think we
Sounds
got
like a
some.
plan.
Yeah, we got something really good there, doc, so thank you.
All right. Have
Fantastic.
a good one, doc. Thanks.
I appreciate it. Thanks, guys.
Thanks for listening to Shielded. At Bickler and Longo, this is what we do. We've represented thousands of first responders across the state of Florida. If you need assistance, don't wait. Please reach out. To learn more, head over to bicklerlaw.com or email us at info@bicklerlaw.com. You can also follow us on Facebook and Instagram at Bickler Law. And if you found today's episode to be helpful, please share it with a fellow first responder who might need to hear it. Until next time, stay safe and thank you for all you do.